Good morning, everybody. Buenos días, doctor Restrepo. Bienvenido a nuestra conferencia.
Buenos días, muchas gracias.
Y gracias por hacer esto. Pues lo voy a introducir, pero en inglés.
Perfecto.
Guys, I just welcomed Dr. Restrepo in Spanish. And I told him, thank you for helping us out. So Dr. Restrepo is a physician and surgeon, Universidad Pontificia de, no puedo ver, Bolívar in Colombia. He's from Colombia. He's a respiratory therapist from Georgia State University in Atlanta, Georgia, my alma mater. I went there before he did. He's a tenure professor at UT Health San Antonio, where he wants me to go for my master's. And who's messing with the computer now? Thank you. He's the coordinator of Research Division of Respiratory Care, Professor Division of Pulmonary and Critical Care, member Editorial Board Respiratory Care and Canadian Journal of Respiratory Therapy. He's a fellow at the AARC and ACCP. He has over 100 publications. He speaks at more than 4,000 national and international conferences in respiratory care and critical care. Dr. Restrepo is a good friend of mine also, so I would like to welcome him for helping us out virtually. Thank you, Dr. Restrepo.
It is my pleasure. Thank you, Linda. Thank you, everyone, just for this nice invitation. I think I'm going to be talking about something that may be of interest to most of you. In fact, we don't use a lot of acetylcysteine, but I think I'm going to just give it a twist. I'm hoping that I spark some interest in learning about just what you see on the title, acetylcysteine and COVID-19 beyond a simple mucolytic. These are my disclosures. I'm an independent consultant for Immunotech. I'm also a consultant advisor and speaker for Medtronic, Draeger, Bayer. So you can see the list anyway. And what I'm hoping to achieve today is follow this agenda, which will be just a brief outlook to COVID, speak specifically, of course, of NAC in regards to mucolytic properties. What about treating overdose of paracetamol or acetaminophen? Also the antioxidant properties, and of course the body of evidence that exists by using NAC for the treatment of SARS-CoV. Also, I'm going to finish with oxidative stress, speaking a little bit about glutathione, which is a biomolecule that you may have heard of, and also about cysteine nutrition and COVID-19. It's quite amazing that we go back to this day in 2020, and we couldn't believe exactly what was going on. Just to realize that the last time you probably saw this ICU like this was just a few months ago. It's been kind of just quite scary. I know that we have still some mutations, some variants that are concerning, but probably not to the degree that we are expecting to see sometime soon. We hope ICUs under these conditions, and of course patients who are connected to every single probably IV pump that you can imagine, and of course the scarcity of mechanical ventilators. And then of course you get to use all of these tools that you learned from the Procedure study a long time ago about proning and the benefits of even proning patients who were spontaneously breathing. Last time I presented this information back in October, you could see exactly the number of cases. And of course, all of this has been really considered to be underestimated with respect to see probably more than 10 million people death, and also over 10 million people suffering from long COVID or COVID long. So this is, I guess, for some of us who are RTs, has been the enemy because we had a chance to smell this from Dr. Joe Rao when he passed this around years ago when I was in training for respiratory therapy. But also we heard that this is not exactly something that you see very often used anymore, maybe in bronchoscopy suites directly instilled to unplug patients, but not necessarily just very often in the critical care or the respiratory care arena. If you look this up on your iPhone, drugs.com will give you just a very nice description of what mucomist is all about, and also being a medication will walk you through to the precautions. So you see, that's probably the issue that we have with many pharmaceutical products these days. You have a bunch of drug interactions, carcinogenesis, mutagenesis. So everything that deals with administering or prescribing any medication to our patients. When you look it up, which is something I would say a little bit more official, is the PDR. Used to be, if you remember, the physician's desk reference. So now it is prescriber's digital reference. But I think it's a good source of information to realize exactly what acetylcysteine is all about, but also just things that you keep in mind. So we know, and I highlighted the words COPD, mucolysis, prevention of hepatotoxicity. We may not, as respiratory therapists, be exposed to this benefit, but in reality, if you have patients, believe it or not, who want to overdose and commit suicide by taking acetaminophen because they did the homework of finding out that this causes a fulminant hepatotoxicity or liver failure, that could be the case. So this is a significant role being played by N-acetylcysteine. Also, nephrotoxicity prophylaxis. Sometimes when you use contrast-induced, again, nephrotoxicity by contrast measures. Also, by treatment of the giant papillary conjunctivitis. Honestly, I had no idea about this. And the DIOS, which is the distal intestinal obstruction. But something that it is beyond the mucolytic as a spectrum is this action as the antioxidant. I'm going to emphasize a lot of this because sometimes, again, we want to learn a little bit more about medications that we have used, that we have seen in respiratory medicine that are used for something else. As I mentioned before, nothing comes without a price, and these are the possible side effects. As you can see, those pulmonologists who are maybe just watching this or will watch this later on will probably just tell me anyway that it is actually pretty safe. According to Dr. Jay Peters, who is our medical director in the ICU and the VA, when I asked him probably about 2 weeks ago in a conversation that we had about antioxidants, precursor for glutathione, he said that roughly only about 5% of patients with COPD are really using NAC in an oral medication. So let's speak about the acetaminophen overdose. And there's reason for that, what this is important. And Linda told me that you will not get credit unless you are able to draw this after my presentation. So just please pay attention to this. So of course, that is not absolutely true. But what is true is that after you have acetaminophen ingestion in an overdose, what is going to cause is this. And I think we started getting used to the word glutathione. So what this happens is that glutathione will be extremely beneficial, but then when you have acetaminophen overdose, what you're going to have is depletion of glutathione, and that is going to lead you to a fulminant hepatic failure. And believe it or not, it could be associated with death. So when you think about increased oxidative stress, you think about liver, because liver benefits greatly from the production of glutathione that happens intracellularly. So if you think about increased oxidative stress, I guess you wonder, well, what is in the literature about this? And you will find a surprise once you get to PubMed.gov that you will find oxidative stress that we probably have talked about just previously in so many instances respiratory-wise that is over, I mean, it's almost 300,000 papers that speak of the importance of the oxidative stress. And then if we were to relate oxidative stress to, of course, reactive oxygen species, and you will see ROS these days everywhere. You don't have to speak only about COPD, asthma, bronchiectasis, CF. You can speak of diabetes, cancer, fibromyalgia, arthritis, and ROS are all over the place. And of course, this has been very well investigated. And now you can see, again, over 290,000 papers. But now let's concentrate again on health to disease, because if you think about what happens with oxygen-free radicals, remember that we appreciate the fact that we breathe very nice concentrations of oxygen, even if it is only, if it appears to be 21%. But the reality is that some of that will convert into free radicals. And the problem with the ROS, with the oxidative stress, is that it affects every single function of every single cell and it has been implicated with hundreds of chronic diseases. So you realize that the mitochondria that you see here could be damaged, but something that is even more important is just breakage of DNA damage. And I will explain that, what the role of the glutathione will be on the repair of this DNA. So we at some point are exposed to all of these things. So cellular damage, if you smoke, that's exactly what it's going to be. UV light, who's free from this? Inflammation, air pollution. So now we want the 6G on our cell phones. Well, radiation is a significant part of the DNA damage that we see on chronic diseases. Very complicated slide, only to simplify the process by saying, take a look at this. Increase oxygen radicals for oxidative stress. So it doesn't matter if you're looking at any particular disease, this could be hypertension, and guess what? It's going to be the same process if we look at the diabetic neuropathy, when oxidative stress and ROS, just the oxygen radicals, are going to be a significant part of the pathogenesis of diseases. And again, I chose something that is very common. So when you realize that I'm not choosing something like Sjogren disease, or maybe lupus is often seen, but it's not as common, and this, you will realize the importance of the oxidative stress. So why don't we just go ahead and tie at this point the antioxidant response to mediated oxidant-mediated lung diseases. And I think you will recognize very easy emphysema, ARDS, hyperoxia, IPF, asthma. So that means that this is not really just coming from just somewhere that has been hidden in the literature. This has been published for quite some time. So again, this is a paper from the American Journal of Physiology, Lung Cell and Molecular Physiology from 2001. So this has been published for quite some time. And I think what is key is that if you look at the pathogenesis, again, I don't want to complicate your life with just complicated diagrams, but even in the core of explaining what happens in respiratory diseases, what we're looking at here with COPD is ROS, just right in the middle of this. So yes, you probably are familiar with, again, the neutrophils, the interleukins, the catalase, the proteases, mucus secretions, and all of these inflammatory mediators. But the key is the center of all of this is reactive oxygen species. That means oxidative stress. And nothing really changes so much when you look at asthma. ROS, or just oxidative stress, is at the core of the inflammatory process that leads to asthma and its complications. So why don't we just go ahead and try now something that is very current, which is oxidative stress and COVID. So is there really a relationship, or is just simply Dr. Restrepo just trying to just pull some strings to make this interesting? Well, it is all over the place. So when you think about maybe my CV and you think, well, my goodness, 100 papers and so forth, I mean, there's nothing compared to the amount of science that has been published around oxidative stress and COVID. Keep in mind, this is only a few years. We're talking about only 3 years, and we have now over 1,000 papers. Speaking of the importance of the oxidative stress and COVID prognosis. So this is one of the papers that I pulled. Okay, so this is a very interesting group in Wisconsin, and it says role of the oxidative stress on SARS and COVID-19. So this is a review. And of course, to complicate matters, is that you have just a bunch of references that speak of the same. Again, this is a relationship to COVID and speaks of oxidative stress, where all you have is the mitochondrial reactive oxygen species. And again, mitochondrial will have a lot to do with DNA changes. No, I don't think at this point, I'm hoping that you don't have any question on why this lingers with patients and now you have COVID long or the post-acute phase. Because if it lingers on the DNA, it will continue just making changes and continue just causing significant changes as a multi-organ failure. So this slide is showing that there's always a balance or homeostasis. We know that word in medicine between the pro-oxidants and the antioxidants. So believe that this is the ROS, this is the reactive oxygen species. And of course, as more you release of this, you actually have a disbalance between the antioxidants and the pro-oxidants. So this is actually the good news. Then you can control the viral infection because you have a good balance between those two. The only problem is that if you are able to have an infection, but then you have a disbalance and your antioxidants are actually just very low, just you have a perpetual cycle. The reason why we learned these lessons from SARS before is that patients were having symptoms 18, 24, 36 months after this. And this is really a good explanation of why this disbalance could be related to the fact that this is a continuous cycle. And it doesn't matter that you believe that you're going to have a reinfection. The problem is the continuous effect that this infection will have in your system when you are not able to optimize the levels of antioxidant. I think it will sound extremely familiar to you that all these changes that we discovered back in the beginning of 2020, and then we didn't know exactly if a thrombolytic therapy was going to be useful. Well, this is exactly what happens with SARS. And then you have excessive radical species, red blood cell dysfunction, thrombosis, alveolar damage. So in the middle of all of this is, again, is the balance between antioxidants and O2 radicals. Now let's narrow this down to what it is about oxidative stress and glutathione. And then you have a relationship between, of course, if glutathione is an antioxidant and oxidative stress causes toxicity or oxidation, of course, it will make sense to tie those two. Over 50,000 papers, speaking of this antioxidant, that was actually discovered back in 1885. And you ever wonder, even as a physician, I asked myself, probably a few years ago, 5 years ago, it's like, I remember seeing this the first semester of medicine. So why didn't I see enough of this? Well, I had to jump all the way back to probably about my 4th year of medicine when I was exposed to IV glutathione, intravenous glutathione, exclusively used by patients or administered to patients in the oncology ward. But in the middle of all of this is to control the redox, to control metal homeostasis and detoxification. In fact, I think the medicine has defined glutathione as the master antioxidant, but also has been clear in explaining that it detoxifies every single cell. So I guess the message at this point here, how do we tie NAC to glutathione? Just give me again just a few minutes and I'll make sure that we come back to the NAC. But the key aspect here of glutathione is that is the guardian of every single cell. And that's why increasing glutathione levels will be useful for any type of pathology. So now if we look at today, we have almost 174,000 papers. And you see the explosion of this again from 1923 all the way to 2023. This is not going anywhere. I have calculated, exactly in a presentation similar to this, I have calculated that in average, we have about 20 to 30 papers on glutathione every single day. I guess we wish we had this type of productivity scientifically. So this is the molecule. This is glutathione. And again, to just land the message back to exactly all of us as respiratory therapists, this is the cysteine. We have heard of NAC. This is in the middle of the glutathione, is the cysteine, and is the most important rate-limiting substrate for glutathione synthesis. So let me translate this. If you don't have enough cysteine, you are not going to be producing inside the cell because the substrate is a precursor. You are not going to have enough intracellular glutathione. So again, if you ever wonder why it was discovered back in 1885, some people claim 1888, it's not a big deal. It's been a long time ago. I was too little. But then you have to realize that if it is so vital to the function of the cell, why is it that we cannot just simply buy this at the gas station? And the reason for that is because it depends on the substrate, because GSH is produced inside the cell. So it requires to be produced and is produced by every single of our cells inside. But again, we have a decrease, a significant decrease after we just go over 20 years of age. So that means that for some of us, where it was like 5 years ago. How glutathione works in the body, you can see, it will drive you crazy to find the significant amount of functions of the glutathione. But I would say in general, it's a good idea because it just it is the immune response. So glutathione is food for the immune system. So it is an immunomodulator. The other one is D because it detoxifies. The other one is energizes the cell, and the A would be for the master antioxidant. A little bit of the background of what we know. Decrease with age. So once we reach 20, it has been calculated. So we are now familiar with the FEV1 decreasing after 25 years of age. Well, it seems like after 20, we don't do very well in so many areas. So this is one of them. GSH decreases 1% per year after 20, 10% for every decade. You can imagine that after you reach 90 years of age, if you do, it's only 5% of the mitochondrial DNA that is normal compared to a 5-year-old. And why is this going to be so important? Because if you are able to, at this point, increase the levels of glutathione and you get to be 100 years of age in a healthy status, you will have GSH levels of similar to 30 to 50 years. So I could have a potential to increase glutathione levels and reach this level of health of a 30-year-old, relatively speaking, even though you cannot just simply pretend aging. But glutathione has been related to the anti-aging effect. So something else about glutathione and now the respiratory system is that you have a relationship of respiratory diseases and glutathione, over 4,000 reviews. And then if you read about glutathione and COVID, over 194 papers, even at this point, which is actually very important. Very complicated slide, but I really like, I highly recommend that you review this work by Polnikov, because I think the title is very enticing. If you think about it, endogenous deficiency of glutathione as the most likely cause of serious manifestations and death in COVID-19 patients. And take a look at glutathione. So all we have to remember is that wherever we see radical reactive oxygen species, there's going to be an issue. Well, membrane, the entire cytosol, the entire nucleus of the cell, mitochondria. So I think it is very clear that, and then there's a new word there's a new acronym I would like for you to investigate, NRF2, the world of epigenetics. Very cool. Again, I can tell you that even as a physician and respiratory therapist, this has been a very exciting field to learn, because again, you get a lot of NRF2 by eating just the buds of the broccoli, not the full one, but just the little one, the tiny ones. So in a center of all of this, reactive oxygen species. So that means that if you were able to control somehow this deficit of glutathione in patients with COVID, you may be able to just change the outcome. So let's see exactly what this says. I think something that we are all very aware of when we heard about this Delta mutation or this variant of the COVID-19 was that we already had recognized some risk factors. If you were old, if you had a specific gender, if you smoked, if you have any kind of chronic illnesses, you had a tendency to die. So now let me tie this to glutathione. If you have absence or you have a deficiency of glutathione, guess what? Your viral replication will be increased to the point, and this is where we recognize something that we are able to probably just manage, ARDS, but then it could be so high that the process of inflammation could be severe for the patients and could lead to death. You may think, oh, this is only for patients. Really, it correlates very clear with the fact that if you have a mild disease, your glutathione levels reduce and the ratios are going to be nothing compared to the maximum or to the severe decrease of glutathione when you have a severe disease. So there's a clear link between the levels of glutathione and the complications from COVID. So let's try to see exactly what the role of the glutathione in protecting against the severe inflammatory response triggered by COVID. And it all it deals is with the ROS. So this is exactly where you could actually prevent this cytokine storm associated with SARS. So let's go back to cysteine, because we were talking about NAC, and NAC is still cysteine. And if you think about it, so inside the cell is where you have production of glutathione, but then you have to think that I have a way to administer at least the substrates or the precursors of glutathione outside the cell. So this is actually what you need to be eating. You don't need to be looking for IV or oral glutathione because it doesn't really reach the cells very efficiently. What the beauty of cysteine is that it is an antioxidant by itself. So now we can start looking at NAC and its function as the antioxidant. So that's nothing new. NAC and COVID, NAC and COVID. So you have seen reports, these are again non-peer reviewed, but then when you look at the literature, we have over 100 papers that deal with NAC and COVID-19. So that means that out there in some institutions, some physicians included the NAC as part of the cocktail to combat or treat COVID-19. But why is it like this? So remember, this is only one example of one of these so many papers of NAC and NAC. I'm sorry, NAC and COVID. And the summary of this is that if you look at NAC here, it is blocking, I mean, it's this massive inflammatory cascade. So of course, it has a significant role in increasing the glutathione level, so you can control all of these changes that occur due to the oxidative stress. Now, this is the twist. So the twist happens at this point because we have heavily relied, again, in medicine in general, I wouldn't say just not only as a physician prescribing with prescribing privileges, but we have relied on pharmaceutical companies to just see exactly what happens. So now, what is the role of nutrition here? So how do we tie nutrition, cysteine, and COVID? Many of you have heard of the whey protein, and I think the whey protein, I mean, we gotta just contact this company just to spell this right. So cysteine is when you have with the sulfide bond 2 molecules of cysteine, which is misspelled here. But there's no question that cysteine is being contained or is being part, not exactly just a huge amount anyway, but because this is only just 1 gram, as part of just many of these powders. And it is very key because it's been shown very clearly that diet could control inflammation by reducing oxidative stress. And if you know that you have oxidative stress in COVID, this will not be the exception. That means that you have a way to modify with diet, leave alone the NAC, with diet, this oxidative stress. And then you start seeing that something that really is very close to what we do. How does this affect really extubation time? So this is a very nice paper by Scarcella, and it showed the effects of this whey protein. And the reason for that is because the better you nourish the patient. Have you heard of this? The patient who has a better metabolic rate, the patient who seems to be having very high levels of albumin or protein, they will perform better if you're planning to extubate. So this is approved. What you see here on the extubation time is that the higher the levels of protein that you have, the sooner you can extubate those patients. And if you look at the cohort of patients who actually died, it clearly showed not only that those patients were taking longer, but again, they didn't have a chance to get extubated, but you see the levels of protein were very low. At the bottom here on this bar graph, what you can see is that if it takes you very little time to reach that protein level, your extubation time will be quicker than if it takes you more than 3 days. So I think we learned a lesson is that we are not responsible for, let's say, the nutrition of the patients, but then now we know something that we can share or we can ask, again, pharmacy or nutrition or the one who specializes on treating patients or trying to just see if they're getting very well nutrition, because no wonder you are fighting to extubate this patient. This is one of the good reasons for that. So I looked up just a few years ago, and I found that there's probably just one nutraceutical agent that is cysteine, and it is a bonded cysteine and is a glutathione precursor. And I showed the PDR because I think it just provides more credibility when you have so many natural products that really don't show up in the PDR. And by the way, they don't show up because there is not enough number of references anyway. So you can actually just look this up. And it clearly says that you have also for the product itself, it's been published over 20 times. By the way, I probably have access to about 82 papers at this point. Many of them are not indexed, but that doesn't mean that they are not peer-reviewed. For example, the Universidad Autónoma de Mexico, the UNAM in Mexico is very well known, but some of those papers don't get to be indexed in PubMed. So this is what it shows. It's simply a supplement. These are some of the presentations that you see in the market. Again, glutathione precursor, the immunocal, the platinum, and sport. And again, it's just beyond the scope of this presentation to tell you what they do, but they are a precursor of glutathione. And if we look at the literature and see what has been published in regards to this particular supplement, there's no question that some of these papers have just related the use of this donor of glutathione of the cysteine in the cases of exercise-induced bronchospasm or even cystic fibrosis. I had decided to take it one step beyond. So a university in Colombia allowed us to use at least four of the patients out of the 120 who received this, what is called the cysteine-rich whey protein isolate, which is actually just the generic name for this type of immunocal. So we published the results of this treatment, or it's actually a co-adjuvant because these patients also received just the regular protocol. So it was not a randomized controlled trial. You could probably just say, well, it's only about 4 patients, but trust me, I take it very seriously when I say case reports in the body of evidence may be not very useful, but if this were to be my mom, my dad, my sisters, that would be extremely important to me. That could actually just prove the point that a whey protein isolate with a good amount of precursor of cysteine could actually just probably save lives or could be potentially added to the protocols to make a difference. Just this month, this paper came out from a Peruvian group. Very interesting. It was a qualitative study, but also again just proves the point that cysteine, again coming from NAC, cysteine now in a natural fashion could improve significantly the levels of glutathione and make a difference on patients with COVID. By the way, again, please keep in mind, NAC, as a conclusion, this is not exactly the first time this has been presented in the literature. We know for a fact that NAC has been associated with limitation or control of duplication and replication of many viruses in the past. I think the reason why as respiratory therapists we do not hear so much about it is because the relevance, I mean, we do not prescribe it, but I think it's an extension of something that we have heard of, that we have known, that we have probably just nebulized. But now there's a new world out there to explain why truly the NAC is clearly more than a simple mucolytic. Even if you actually dig down into NAC, you will find that it even suggests that can control or may act in the prothrombotic state that has been clearly defined for patients with COVID. I think we have probably just more to learn. I think one of the conclusions that I could make is that even as respiratory therapists, we have to be aware that there will be just some natural medicine, alternative medicine that we probably could dig in, could actually improve our knowledge because it really affects the patients. So let me just say something else that in the past for patients with COPD, NAC up to 600 milligrams a day was relatively commonly used, if I could say that, because of the antioxidant properties. COPD is an inflammatory process. We all know that. So as a consequence, anything that you could do at one point with NAC to improve glutathione levels, it could be beneficial. The only problem is, again, you have to take this every single day. The cell requires the removal of this reactive oxygen species on a daily manner. The more you are heavily exposed to UV light, contamination, radiation, stress, I mean, you name it, it has been a very close relationship between those exposures and increase the levels of oxidative stress. So I'm just hoping that this brings kind of just a new way to look at few things that we have used in the past that could really make a difference on this particular case. So with that, I want to thank Linda again for the invitation. I want to thank also Heather for coordinating just behind the scenes. I'll be happy to answer any questions. And so with that, I thank you again.
Thank you, Dr. Restrepo. And the stuff that he spoke about, I actually take the stuff. So he yells at me when I don't take it on a daily basis. True?
And I do.
So I get nasty text messages, but I do take it. It has helped me get my A1C down. It tastes nasty, but it works. Let's be honest. So sometimes the nasty taste is not good, but the outcome is very beneficial. Are there
Hello.
any questions for Dr. Restrepo?
Hello.
Hey, Carlos.
Hey, how you doing, Dr. Restrepo? Good morning. It's been a pleasure. I really enjoy your lecture. I learned a lot. Question, please. Thanks God we don't have the pandemic. It's been scary. Would you suggest that mucomist can rescue mitochondria? Because very much that's really what's going on in the COVID patient, that mitochondria shut down, and we have patient with COVID with severe hypoxia. I worked a lot in ICU with all these patients, and I saw them coming back when stream, high level of P, put in position, in prone position, et cetera, et cetera. But my question is very straightforward. You think the mucomist can rescue the mitochondria when they are really shut down the whole system? Thank you, Dr. Restrepo.
Carlos, that's a very good question. I think the potential for NAC is something that is beyond what we believe in. I think the science is very simple in regards to that, Carlos, that if you optimize levels of glutathione is very, very, very key to mitochondrial repair. It is very clear. Whatever the science you look at, you don't have to look into the nutritional medicine. Just look at the PubMed. And once you look at improving glutathione levels, that's the key. So the key is NAC. I don't have a lot of experience with NAC just per se, just being used as coadjuvant. But the evidence is very clear that if you add NAC to these protocols, you could get an additional benefit, and the benefit arises from mitochondrial repair. It is absolutely based on evidence. I think, Carlos, I will have to say, as everything else in medicine, and particularly in the ICU, people who hate APRV have a tendency not to use it or not to know it, and I think that's the case with NAC. You really have to know how to use it, having a very routine protocol on what type of dose you're going to be administering, what type of IV medication you're going to give, according to according to the protocol. I think, Carlos, the science is out there. It's very clear that you can do that, and it is clear that it could improve mitochondrial response and function. I think it's just worth giving it because even at those levels, it doesn't really have so many side effects. Now the key is, as Linda said, if you have natural options, well, I think it is clear that I have used the nutraceutical, the protein isolate of patients with COVID in about 10 different countries, and you'll be shocked to see the response of this cysteine, this donor of cysteine, improving glutathione levels. And again, the rest is written because, of course, mitochondrial function had to be improved.
Thank you, sir. Thank you. Thank you very much, sir. Thank you.
You're welcome.
Any other questions?
Is there any interactions with any other medication that you take right off?
Is there any other indication? What was the question again, John? Any interactions with other medications while taking the immunocal?
No, absolutely not. The simplest way I could explain is that since it promotes cellular repair by increasing glutathione, honestly, this nutraceutical doesn't even shake hands with chemotherapy or insulin or metformin or anything like that. So the way pharmaceutical products will go to the cell will be a completely different pathway. There are no known drug interactions. In this particular case, this donor of cysteine has been investigated for about 45 years. None at this point. And I have used this with actually so many patients who are taking even medications that I have no idea about. There's no drug interaction.
Also, do we have to follow any liver function test?
Do we have to follow any liver function test or kidney labs?
Say that again?
Do we have to follow any liver function test or any blood work for the
That's-
kidneys?
No, that's a good question. The simplest way I can explain, again, people who work as consultants with me is this. Not everyone has to be knowing about creatinine or just a BUN, but I think the key is that any nephrologist will direct the renal patient to a nutritionist to say how many grams of protein you have to take every day. So it's not really so much about the labs, because it doesn't impact liver function. Well, it will improve liver function, but it is just being aware. Can you have a protein restriction, realizing that what I do take, for example, every single pouch that I take is 10 grams of cysteine. It is just getting bonded, so that means it's 10 grams of protein. So if I were to be a renal patient and somebody restricts my protein intake to 60 grams, I need to take into account that when I recommend Immunocal, and I recommend 2 pouches of 2 seconds, I am already saying, please keep in mind you already have 20 grams on board. Now it is up to the nutritionist to sit around with you and negotiate the remaining 40 grams that you have to take. No labs, it's just simply common sense. How much protein are you restricted to take? Keep in mind that every single pouch would have 10 grams of protein.
Anything else?
They mentioned about A1C, so this actually helps the diabetes.
So since I mentioned about my A1C going down, he wants to know if that can actually help with diabetes.
Oh, I'm going to be careful with saying this, whoever asked the question. Absolutely. Something that I haven't seen really in traditional medicine is how a patient taking a glutathione precursor like this could drop A1Cs by 3 points in 6 months, or just by being redirected in regards to prescription, that no metformin, no insulin. So I've seen the whole spectrum. I think it is very hard to speculate what type of result. I think what I typically say is, remember that even in medicine or pharmaceutical products, you have something called individual response. So I don't think any reputable endocrinologist could actually guarantee that with metformin or this type of insulin, you're going to get a reduction of A1C in so you couldn't do that with a nutraceutical. But I have seen even reduction or improvement of retinopathy. So my message to you is, please do not underestimate the fact that even if many companies actually produce glutathione. I don't know who they're trying to fool, but increasing glutathione levels could make a difference. It is not just simply just one disease. I think the science is clear. There are hundreds of diseases clearly medically, scientifically documented that are linked to a decrease in glutathione levels. So I think what I'm doing for my life personally at this point, after, let's say, finding out about 5 years ago, is improving my health. So cholesterol, hypertension, allergies, well-being, muscular resistance, endurance, all of that. It's because glutathione just simply does that. So if you find a way to improve glutathione, I think the benefits are just enormous.
There was also weight loss.
He also mentioned about the weight loss.
Yeah, weight loss, yes, because what is the key with weight loss? At least some part of the weight loss is metabolic disturbances. Metabolic disturbances, if you actually type glutathione and metabolic disturbances, as I have a physician talking about obesity, metabolic syndrome next week. Fortunately, it's going to be in Spanish in my program. I do have a program on Thursdays via Zoom, but the key is any type of metabolic disturbance. And every single time we time metabolics, we're going to be thinking about mitochondria, ATP, and all of that. There's a significant role of oxidative stress in weight gain. if you regulate that, I guess my individual response has been, my weight in the last 5 years has fluctuated no more than 5 pounds. So it has to do with just metabolic rates.
Okay, anything else, guys? So, thank you, Dr. Restrepo. Hope to see you
Thank you,
live one of
guys.
these days again soon.
Absolutely.
And if John
Guys,
wants
take
to,
care.
and if
Enjoy
John
the
wants to
rest of
try
the
the
conference.
and if John wants to try the immunocal, I can give him one of my packets.
Yes.
Absolutely. See you
Okay, I will
guys.
get it to you,
It's been a
John. Bye,
pleasure.
guys. Bye.
Take care.
Thank you.
You too. Bye-bye.